So we are going to be listening to a team of 3 midwives who are providing midwifery-led care, capacity building, and mentorship in Rohingya Humanitarian Response. And this is to reduce maternal and neonatal mortalities and then save lives. We have Elestina, we have Kindness, and we have Shompa. So over to you, our presenters.
Thank you so much, Bernice. Indeed, we are a team of 3, as Bernice has explained, and we have divided our presentation in 3 phases. I'm taking the first phase, then Kindness will come with the second, and then Shompa will take us through the third phase. So my name is Elestina Yvonne Phuka. I'm an international midwife mentor from Malawi, but currently working with UNFPA Bangladesh. Yes, so I'll start with the background. In the background, we have the context, and then the maternal health status, and what is the crisis, and what is the strategy. So to take you through the context, Rohingya refugee started in 2017. There was an influx of about 1,000 population, and currently it's about 1,200. So as we are aware, irrespective of where mothers are, whether they are displaced from their homes, whether they are on the move, we are still going to have pregnancy, we are still going to have children being born. So with this influx also came with the need for them to have access to health care, which included sexual reproductive health care. So UNFPA came in to take lead to provide the quality sexual reproductive health care, and it works in a group of partners who are also working in the Rohingya response, a total of 33. So when UNFPA started to respond, we discovered that there's a problem of high mortality rate. So then we have a target, as you all know, with WHO to have at least, to reduce the maternal death by at least 70 per 1,000 life births by 2030. But for our situation, it's at 1,360, which is still on the higher end. And then, as of 2025, we had at least, although we managed to reduce the maternal death, we still had a higher end with at least 3 maternal deaths in a month and 15 newborn deaths in a month. And the main causes being PPH, severe preeclampsia and eclampsia, prolonged and obstructed labor, and then with it came fetal distress, birth asphyxia, and then we also ended up having sepsis. So what we noticed is that in Bangladesh, midwifery is a pretty new profession. It's within 10 years, and in the working area, we are having most of the graduates with limited longer stay on the job. So that's when UNFPA thought it wise to bring a strategy whereby we should have expert international midwives and then a team of national midwife coordinators and clinical mentors, so that when these midwives, although they are well trained in the college, but they don't have a lot of experience on the job, we should work in hand to make sure we build the right competence and the confidence in them so that they are able to provide the quality SRH services according to ICM and WHO standards. Next slide. So what approach did we use? We decided to use a mentorship model, as I've explained, on job, and we have the following hierarchy. So we have a sexual reproductive health unit, which is head by a reproductive health team lead. And then there's a team of international midwife mentors. We are 4 of us. And then we have 3 midwife mentors and the 4 clinical mentors as well. So how does it work? We mentor both the midwives and the doctors to make sure that we build the teamwork so that they are on the same page, they are able to implement and understand each other on how to use this approach. And then we use the cascading approach because from the midwife coordinators and the clinical mentors, we have now a team of 15 midwife supervisors. And then from these midwife supervisors, we trickle down to at least 450 midwives who are working across the 33 sexual reproductive health working group partners. So how do we do our approach? Based on the challenges we have, remember we are doing mentorship. We are already having midwives who are already qualified. So we are not reteaching the whole midwifery. We have areas of focus depending on the gaps we have, because our aim is to reduce the high maternal rate. So we have the following focuses. We developed a package of midwifery life-saving skills, which includes respectful maternity care. Then this one is purely for the midwives. We start with the new employed midwives so that we establish where they are with the competencies and the knowledge. And then when we build them, then we bring in doctors, we train them together to make sure that they have teamwork. Then we also combine with respectful maternity care to make sure that they are not just providing the quality skills and the standards, but they have to provide in a way that they are using patient-centered approach. The patient is comfortable, the dignity of the patient is restored and is respected, privacy is provided, and patient's views are taken into consideration, as well as the cultural aspect of the patients, since these are people who are also in a new environment. And then we added to make sure that we build the right attitude for the midwives. So we also added ethics in midwifery, and then we make sure that our team of mentors also have leadership management, and then we also orient them in the use of technology so that they are able to correct real-time live data. Next. So the mentorship approach, we do bedside facility mentorship as well as offsite. So for the bedside facility mentorship, here we use 2 approaches. The first approach is day-to-day. We go in different health facilities. We do supportive supervision, and depending on the gaps we're identifying, we prepare. It can be one-to-one or it can be a group, depending on the situation. And then it can be spontaneous. We can find a procedure being done, and then we come in, or we can as well schedule a capacity building session if the facility is quiet. And then on this one, we also do case reviews, and then we also do analysis of how the management have been done, and we also check the deliveries which have been done maybe for the past 24 hours or the past 48 hours. And then we also do facility assessment to make sure that it has the right needs to meet the provision of MOC standards. So we check the facility, the environment, the medication available, and then the protocol to make sure that every reference is according to the ICM and WHO standards. And then for the off-site training, these ones we provide not only to UNFPA implementing partners, but to all the partners who are working in the Rohyinga response. So this one, we now schedule the trainings depending on the gaps which we are identifying now according to the data. The reports, the data, where the challenge is, and then we also use the MPMSR reports. We do have special reviews with experts of SRH, and then we are able to come in and give midwifery expertise. And from there, the recommendations which we are going to agree, we are able to come up with the trainings to meet that gap. Next slide. Yeah, thank you. Yeah, so how do we keep track of all this? And how do we manage this data, which we are always referring to say we use the data gap-based? So starting with the trainings, whether it's the bedside training or maybe it's the offsite training, we make sure that during the sessions, we have checklists so that when we're doing these sessions and then we do written demonstration, we are able to check according to the procedure how the midwife is performing. And then we are able to come and give feedback depending on the way the midwife performed so that we are able to build where it's left or even give positive feedback if the midwife followed according to the procedure step by step. And then how do we track all these different approaches on our side? Now here we have a different tools which we use or through Kobo so that it's online. We are able to check and follow every facilitator, and even us as the international midwife mentors, when we go, we are able to log our space. And then our team of national mentors, the midwife coordinators, and even the midwife, the clinical mentors, they're able to log in. So everyone, when we have gone to the facilities on everyday basis, there's a section you select according to what you did, and then you record. And then this has just been updated to make sure that by the end of the month, it's already giving us an analysis on how we performed and where the gap is. And then we are already able to interpret and then plan the next focus for the next quarter or the next month. And then what else has this data helped us to improve? We have also just introduced a high-risk ward at one of our CMOC facility, and we made sure that we developed a tool so that they are guided on how to provide high risk. And this one, to be specific, is antenatal. One of the challenges we discovered that if there is a high risk during antenatal, that they can have a difficult delivery, or maybe there's already a history of difficult delivery. For example, previous PPH, or maybe there was a prolonged labor. We are able to bring these mothers close already to CMOC facility. And then when they come, we are able to manage the challenges they're having with the pregnancy. If they stabilize, we are able to use this tool to reassess them, and then they can go back, or we are able to admit them so that before the onset of labor, they are already in a CMOC setting, and we are able to provide timely care to prevent the delay which comes in with the referral process. So let me hand over to my colleague, Kindness, to take us through the next phase. Thank you.
Thank you very much, Elestina. I want to continue to talk about the impact on all of what we have been doing on maternal mortality. And we have realized that this has been able to help the midwives do prompt management of obstetric emergencies. Midwives are mentored to confidently and independently identify and manage obstetric emergencies like PPH. Now, how is this done? From the onset of their employment, most often they lack a lot of confidence and they lack a lot of skills. So with this, our mentorship, what we have been able to accomplish so far is that we have built their confidence to such an extent that they can independently do this identification. And as we all know, to be able to effectively manage an emergency, the first thing that comes first is identification. If you are not able to give a good diagnosis, then management automatically is delayed. So we have built the capacity to be able to promptly identify emergencies and manage so that the delays related to decision making can also be avoided. And as such, one of the most critical delays that leads to maternal death is being handled. And we have also been able to help them do standardize tools and protocols Elestina has mentioned tools, so we are going to protocols. Most often, protocols are being misguided. Everybody comes from a different school of thought, and we all have varying protocols. So we are able to guide them to stick to ICM protocols, WHO protocols, and other standard use protocols that will guide them to better take care of the patients and manage. This is to ensure that the midwives follow safe evidence-based, starting with ANC for a healthy pregnancy. Most often, there was a confusion between the midwives and the doctors on which protocols are best to be implemented. So this continuous mentorship and building, bringing the midwives and the doctors together, has been able to help them stick to the same protocols, use the same approach to emergencies. And yes, again, it has been able to reduce the delays related to decision taking or decision making in managing an emergency. And as such, what is the impact? It has been we are able to also prevent avoidable deaths. When you are able to intervene timely, manage effectively, and make critical decisions, deaths could be avoided. Again, we are talking about delays in decision making. When this is handled promptly, we have been able to help these midwives build their confidence, build their skills to make these decisions such that they can comfortably, or we can boldly say, it has impacted the drop in maternal mortality, because they do timely interventions, and they effectively manage complications. Next slide, please. Okay. Again, Elestina had mentioned that significantly maternal deaths have been reduced. Statistics from 2022 to 2024 stated that it dropped from 59% to 46%. And until 2025, it has dropped from 46% to 20%, whereby we have said deaths have been reduced from 46 to 37 through the Rohyinga Humanitarian Response. How did this come in place? Because we have successfully, through the mentorship and side-by-side, one-on-one mentorship with the midwives, build their confidence, build their skills, and their independence to identify and manage emergencies and timely interventions. As a result of that, successfully, we have been able to minimize mortality. Yes, the milestones may seem little, but step by step, day by day, we are getting to somewhere. What is also the effect? We are not only focusing on UNFPA midwives, but we are mentoring 450 midwives from the Sexual and Reproductive Health Working Group, which means that we are doing mentorship throughout the camps. We have 33 camps, and we are making sure that at least in a month, we visit a camp where we are able to do what? On-site mentorship, capacity building, and do death reviews and case reviews. This is something that we are trying to bring into place, because most often near miss is being neglected. But we have been able to mentor these midwives, all the 455 midwives yearly, where we do reviews on near misses, we do reviews of maternal cases that they had missed out on, and this has greatly built their confidence. And it has also improved clinical adherence. With our management and consistent mentorship, the midwives and doctors are able to adhere to the protocols. Sometimes it's easy to say we have protocols, but the ability or the capability to adhere to those protocols need constant follow-up and monitoring. So our constant presence and mentorship, together with our national team, has been able to bring them closer to the mastery of protocols that stays within ICM and WHO, to make sure that they are global protocols that they are practiced, and it's uniform throughout the camps. Next slide, please. So from this, what are the lessons learned from the Rohyinga Midwifery Mentorship? We have been able to do an integration where the national system models paired with international midwife mentors and national midwives, cultural and language ensured effective communication. Now it's understandable that we, as international mentors, we could have been having, or we are having, challenges with the cultural approach and the language, because yes, the midwives don't, most of them are not fluent in English. So because of that, our national team has been a very big support system to us. Side by side, mentoring the national team to become leaders and national leaders. They also have acted as an intermediary between us and the midwives, and even us and the patients, because it's not just about the midwives, but sometimes we need to pass through the midwives and also have a direct contact with the clients to understand their needs, to be able to also put respectful maternity care into action, because that is part of our priority. And the only way we can push these midwives to make sure that that is done is if we, as the mentors, are able to implement that practically. And then the focus on the big five causes of death, which is PPH, eclampsia, prolonged and obstructed labor, fetal distress, and bed asphyxia and sepsis. Our mentorship, as Elestina has mentioned, is not generalized. We have focused it down to the major problems or to the major reasons or focuses of death, because we want to ensure that that is handled. Nevertheless, we are not only focusing on that, because prevention sometimes will prevent management. So in as much as we put in so much effort in mentorship and building their capacity in managing these big five, we also try to ensure that side by side, we come in with prevention first, which starts from antenatal care. Because if we are able to successfully prevent the occurrence of these diseases, starting from what? High risk identification, follow-up, and management, then we will not have the complications that come when prevention is left out. Again, because we focus on these five causes, death rate or maternal death rate has reduced to 20%, which is not much again, but we keep pushing and hoping that with continuity and persistence, we will be able to do better. Next slide, please. I will hand over to my colleague Shompa to continue from here. Thank you.
Thank you, Apu, kindness. I am Shompa Shohid. I am midwife, and now I am working as midwife coordinator in the Rohyinga Response in Cox's Bazar, Bangladesh. And I work in the sector of midwifery skill development, training, and respectful maternity care. I am going to share with you the points, the cascading midwifery mentorship, how we are cascading the mentorship here in this context, and trying to improve the capacity of the midwife. So at first, I would like to share that we have trained 35 national midwife coordinators who are representing the 33 SRH working group partners in the Rohingya humanitarian setting. And these participants are also certified today here in our program, and in the IDM celebration. And I would like to share that midwifery coordinators have been trained with using a model, which is a model like training of trainers. And this especially addresses health quality by standardizing high quality care across different partner organizations, so that we can ensure every woman receives the same quality evidence-based care, that whenever or wherever the mother enters for taking any services. And we are trying to implement this and monitor this by using some other tools. And I will share that in the next slide. Next slide, please. Thank you. So about the continuous professional development, how we are trying to continuously developing this professionally, develop this professionally. Currently, we are already using the midwifery logbook. The midwives are mentored to track their own performance and progress of their clinical practice on the procedure they have included in their capacity building plan based on individual or group clinical competence plan actually. And they each midwives have their own logbook, and we are following that up. Midwives can find out their own gaps, and we are trying to improve that by doing trainings, everything, and also by doing the bedside mentorship. And then the next thing is competency assessment. The competency assessment Kobo tool, which we are which is in our plan to develop, and this will help to establish a baseline data for newly recruited midwives who are working in this Rohingya humanitarian response. And again, we have another internal quality improvement which will help our midwives and also the doctors or other staffs who are actually working in our facility. And we are trying to strengthening database internal SRS working with midwifery coordinators, facility manager for in their internal evaluation, and this will help to plan individualized gap-based need for the midwives for effective bedside clinical mentorship. Also, it will serve as a long-term assessment. And also some we can use it, we will use it as a one-time of short-term assessment by taking the pre-test and post-test of the midwives. Next slide, please. Yeah, and clinical bedside peer-to-peer mentorship. And about this, we are using some digital support. We are using some apps also, and for the smartphone or tablets, strengthen the use of safe delivery app by WHO. We are using it. All our midwives are trained in this, how to use it. And the specialty is as this tool works offline and ensuring support is available even in the remote setting. We are using this in this Rohingya humanitarian setting. It is a very low resource working environment, and it can save a lot of patient resources to use the visually enhanced mental simulation chart to real medical equipment and save it for patient use. And it is as these are low cost simulation, this helps us to continue our mentorship program very smoothly, so that all our midwives always they are in track to develop the skills. Next slide, please. Yeah, so now about the call to action. So we are what we have been planned to invest in the future maternal care, so that the mechanism we are using, and this so that this is continued. And it is about time to put the place to action to ensure no one is left behind in assessing quality SRH and midwifery care. It is a fundamental human right to enjoy a healthy pregnancy, safe delivery, safe respectful postnatal period, and of course healthy mother, and also vibrant health newborn. Sustainable structured midwifery mentorship, one of the cheapest method to achieve adequate competence midwives to serve all women and babies. And we are doing the strategic investment priorities account balance wallet, and these are actually the actions we have in our plan, and we are also doing. And this was all from my side. Thank you, everyone. Thank you.
Oh, are we done with the presentation? Okay, thank you very much to our three presenters for giving us such an insightful presentation on midwifery mentorship in humanitarian settings. Settings. from the presentation, you have highlighted how structured relationship-based mentorship is able to help even strengthen midwives' capacity. And also, I saw something around helping to create standardized protocols in order to facilitate or improve evidence-based practice. And at the end, all of these, the aim is to reduce maternal mortalities and neonatal mortalities as well, and also save lives. And so we are very, very grateful for your presentation. Now the floor is open to everyone here who wants to ask a question or share a reflection. Please, if you can raise your hand, or you can also put your question in the chat. Do we have any question for our presenters? Let me see the chat. So we have Joy. Yeah.
Hi, and congratulations very much, Elestina, Kindness, and Shompa, for your fabulous presentation. So I'm Joy. I'm working as the International Midwife Specialist for UNFPA Bangladesh. So I'm based at the national level, and our wonderful team who have just presented are based in Cox's Bazar, where the Humanitarian Response is. I just want to acknowledge the amazing, fantastic work that they are doing, and to explain why this has a double importance, not just for saving lives of Rohingya women, which it is doing, and the host communities. And even though you said it's a small reduction, it's actually a huge reduction. And you know, I think you are really to be congratulated and commended for having such a targeted, strategic approach to identifying the areas, the reasons why women are dying, and then having a very focused intervention to address that. It's really fantastic. It's also important not just for the Rohingya women, but it's important for women across Bangladesh, because as our presenters said, Bangladesh has only had midwives in the workforce, in the government workforce, since 2018. They started to work in the camps maybe 1 or 2 years before then. But so far, there are very few opportunities for midwives to practice as midwives nationally. We have 11,000 plus midwives licensed, but so far only 2,500 jobs in the government sector for midwives. So these 500 midwives who are working in the humanitarian setting and getting such fantastic mentorship, they are going to become, most of them are going to become government midwives in the future. I know, and I'm very pleased for her that Shompa has just been selected for the next round of government jobs, which is really exciting. A lot of the midwives who have been trained in the camps are then, when the opportunity comes for a government job, they're moving to working in the national setting. So often I have to defend, as someone at the national level, why do we have these international midwife mentors, you know, just working down in Cox's Bazar? Surely it's not cost effective. And my response is, it is, because they're not only saving lives there, but this model of mentorship is ensuring that the midwives who are going to come into the next round of government jobs are doing so with all of the skills and competencies that they need to save lives. So it's not a question, just a comment acknowledging the fantastic work that our colleagues are doing and the significance that it's having on the national scale. And Bangladesh also is, in the future, the government is very committed to exporting midwives to other countries. We don't want them to leave Bangladesh because we need them, but we know that in future midwives from Bangladesh may go and work in other countries. So it's also an investment in the future of midwifery around the globe when we have this really fantastic mentorship program on the ground in our humanitarian programs. So thank you all for your amazing work. It was a really fantastic presentation.
Thank you very much, Joy. Susanna.
Yeah, I also wanted to congratulate you for all the work that it has evolved. And I have two questions, and actually the second question is coming after Joy's comment. The first one is, what are the most challenges you have encountered providing this? I think at one point you discussed about continuity of care. How does it look like in your work? Is the client seeing a group of midwives, especially when I'm thinking about maybe I'm very naive and I'm very ignorant in all this in the setting, of course, but I just wanted to hear about how does continuity of care looks like. And the other question for Joe is actually this comment about the plans of sending midwives to other countries. I think that is interesting fact when the country who could actually benefit on retaining their midwives, especially when they're very well trained.
You are muted, Phuka.
Thank you, Susan. I'll take the first question about continuity of care. I think, as you know, in a clinical setting, there are different shifts. They cannot work 24/7. They need to change shifts. Another shift will come, the other one should come in. So that one has been a challenge when it comes to clear and effective documentation. As you know, when we are focusing about maintaining the emergency and all that, it has been an issue of bringing an attitude change or understanding change for them to know that documentation has to be done alongside. You are responding to an emergency, you do task allocation, ensure there's someone who should take time and then take notes. But with the limited availability as well of resources, yes, we have the midwives, but they are not up to that adequate, which we might comfortably say we have enough. So sometimes you find there can only be maybe 2 midwives on duty. So we have been meeting complaints like, oh, we had a lot of work to do, so documentation, it's delayed documentation. Maybe it will be done after some hours or maybe even after a day. So you see, you lose important things, let's say like the actual time of what happened. And there can even be a recalling bias. So it's like we have been focusing to also change retrospective documentation so that they should be able to capture what happened without fine-tuning anything, without trying to bring what looks like clean data while missing out aspects. Another thing is with the issue that we are developing the midwifery now, the confidence when it comes to teamwork with the doctors is developing now. Otherwise, initially, we could meet issues like when we come in, we are checking things. We could meet issues like maybe it's the doctor who prescribed this, vis-a-vis what is the protocol and my guideline to this specific care is saying. So for the midwives to stand, even if they know, but for them to stand and then maybe discuss with the doctor what the protocol is saying or the guideline, it has taken time because they haven't been able to stand confidently and then be able to do teamwork. That's why we brought in now the OBLS. Yeah, and then Kindness wants to add something.
Okay, thank you very much. Elestina, just to add up to what Elestina has mentioned, regarding continuity, as you have asked, yes, first of all, we don't work in the camps all day. We work till about 3-4 p.m. and we are gone. But how does continuity of care continue between the midwives and the clients? Vis-a-vis us ensuring that the guidelines SOPs are still being maintained. We have our national team who are on constant basis standing as on call. Should in case the midwife faces a challenge and is unable to manage, the national team, they are 24/7 available to guide these midwives. In addition to that, as Shompa had mentioned, we have the Safe Delivery app that we have tried to empower them to use it as much as possible. So where they face challenges, they are able to go to this app and seek care. At the same time, the medical doctors that have been trained also are on call basis. So without us being on the ground, there is continuity of care because everything has been made available such that where they find difficulties, there is always someone they can run back to 24/7. And this is being ensured because with the follow-up tools that we have and the logbooks, they are able to put in their challenges, their reports, and from this, we know their points of needs, and we understand exactly what we need to do to mitigate their challenges. By so doing, we are able to ensure that respectful care and quality care is continuous with or without our presence in the camps. Thank you.